Dear students, I would like to demonstrate for you today the main parts of the ear. I will have two demonstrations, two lectures. The first lecture will be from the external and the middle ear, and after, in the next lecture, you will hear about the internal ear. So if you see here this picture, it shows you the main parts of the ear, the vestibulocochlear organ. It has three different parts. The first part is the external ear. In the external ear, we have to talk about the auricle. We will show you the external acoustic meatus. And there we can see the eardrum, which is the border between the external ear and the middle ear. In the middle ear, we can find the tympanic cavity. I will show you the borders of the tympanic cavity. Here you can find the auditory tube, which is the connection between the tympanic cavity and the pharynx. And there I will show you also the bones, the auditory ossicles, which are located within the tympanic cavity. And finally, in the next lecture, I will talk about the internal ear, which consists of the ossal part, the bony part, and the membranous part of the labyrinth. So let's see first the external ear and the auricle. We know that the basis of the ear is elastic cartilage, and here you can see the external auditory canal and the external auditory meatus. Around this, we can see the ear, and this main part is called helix. And with this, we run the anti-helix here, and between we can talk about the scapha. This is the Latin name of it, the concha in the middle, and the triangular fossa between the two main parts of the anti-helix. And it is really important to mention the tragus, which is located in front of the external acoustic meatus, and it could be painful if you have inflammation within the external ear. So the doctors, they can examine, and also you can check yourself. If it is sensitive, it means that you have an inflammation within the external acoustic canal. And in front of, you can see the antitragus, the smaller protrusion. And I hope you remember the elastic cartilage. We told you when we saw the elastic cartilage that it is not able to regenerate. So if you have a trauma there in the ear, it will have a very special shape because the elastic cartilage is not able to regenerate to the normal form, just in this amorphous shape. It is well known that we have different muscles which are able to move the ear, anterior, superior, and posterior auricular muscles, which are the parts of the facial muscles, and these are innervated by the facial nerve. And in humans, these muscles, they are not so huge, but we know very well that in animals, they have really important function to show the emotions of the animals. I would like to tell you a little story about that how important is the shape of the ear. When I was in Easter Island, then I heard the story. You know, there in Easter Island, there were people with long ear. They were the higher caste, the richer people. That's why all of the statues, they are with long ear. So the people with short ear, they did all of the works, and they support them, they serve them. And unfortunately, because it is, you know, just a separated island, they used everything, all of the trees, to build these very big statues. So that's why they had no more thing to eat. And the people with long ear, they started to eat the people with short ear. And this is how the cannibalism started. And this was why the big revolution started. and they destroyed all of the statues. So this is the story about the Easter Island, which shows you how important is the ear and the shape of the ear. So here you can see the innervation of the ear. I hope you remember the auriculotemporal nerve, which is the branch of the trigeminal, which is located in front of the external acoustic meatus. And you know, here, this part around the external meatus, there we have to mention the vagus and the glossopharyngeal nerve. It has really important clinical function because during the examination of the external ear, you can activate vagal reflex, maybe coughing reflex or vomiting reflex of the patient. So you have to take care to work on the external ear of the patient. And the lower part and the posterior part is supplied by the branches of the cervical plexus, the great auricular nerve and the lesser occipital nerve. You know, these are the sensory branches of the cervical plexus. And please don't forget that the facial nerve has also sensory fiber, which is involved in the innervation of the external ear. So these are the nerves, what we have to know. If you see the picture from the external acoustic meatus, this is the border between the external and middle ear, the tympanic membrane. The tympanic membrane is fixed to the bone with the sulcus, with the tympanic sulcus. We can divide the whole external acoustic meatus into two main parts. There you can see the cartilaginous part with cartilage, and this, the deeper part, is the bony part. And there in the cartilaginous part, we can see special hair follicles. They are called tragus, and here we have special glands which will form the cerumen, a special sebaceous-like secretion of these glands. They are really important in the protection of the external acoustic meatus, and of course you can see here championship of the length of this special hair follicles. There you can see this, the secretum of the glands within the external auditory canal, and of course that sometimes it's not, sometimes we have to clean it, of course. And it is really important that in this case we can ask the help of the doctors. They can see the external acoustic meatus because it is not straight. That's why during the examination they have to move the ear upward and backward, and that's why it will be straight, and we can look over the tympanic membrane. And in this case we have to take care of the vagus reflex, you know. And you can see the cerumen within the external acoustic meatus. And we can treat it like this with fluid or with a special instrument to clear the external canal. But which is really important, that it is inhibited to do it at home with a very special instrument, because just you push backward or towards the eardrum this whole cerumen, or maybe you can destroy the eardrum. And in severe cases, you can destroy also the bones, the ossicles, which are located within the tympanic cavity. So please don't use this instrument to clear your ear. Okay, so after, I would like to continue the description of the eardrum. Here you can see it's located between the external ear and the middle ear, and it is not in the longitudinal direction, it has an oblique direction. It's located like this, within this, is fixed with an annulus, with a ring to this sulcus there. And we can divide the eardrum into four main parts, and in the middle you see that protrusion which is formed by the first ossicle, which is the malleus, the manubrium of the malleus. It will form this protrusion on the surface, which is called the malar stria. In the middle, we can see this part is called the umbo, and this is formed by the process of the first bone, malleus, is called malar prominence. And from this will originate two folds, the anterior and posterior malar folds towards the anterior and posterior side of the eardrum. And we can divide the eardrum into two main parts. The upper part, which is fixed to the tympanic incisure, is called the flexed part, pars flaccida, because it's movable, compared to the lower part, which is called pars tensa, is a fixed part of the eardrum, and it's located there. It's fixed to this angle. Okay, and finally here you can see the layers of the eardrum. We know the eardrum is located between the external ear and the middle ear. So the outermost part, which is towards the external ear, it's covered by the stratum cutaneum, and the innermost is covered by the stratum mucosum, and between them the fibers, they are located in the radial form and the circular form to form two additional layers of the eardrum. If you see the normal picture of the eardrum, it's like this. We have a special reflected cone in the anterior part, but of course it will change if we have disorders. So for example, in case of chronic otitis, here you can see a big foramen there in the eardrum, or in the acute case you can see the level of the pulse, which is located within the tympanic cavity, and it is also visible that the eardrum is bulging like this, and of course the patient will have very big pain or fever to show the acute inflammation of the tympanic cavity. After the second part of my lecture is the description of the tympanic cavity and the middle ear. The tympanic cavity, if you see the cavity from the anterior view, here you can see the lateral border, the lateral wall of the tympanic cavity, which is formed by the tympanic membrane, and that's why it's called the membranous wall. The other, which is next to the internal ear, is the labyrinthic wall. Here you can see the bony labyrinth. It's called labyrinthic wall or medial wall. On the surface of the medial wall, here you can see the protrusion, which is formed by the cochlea, the cochlea of the internal ear. This is called the promontory. And on the surface of the promontory, we can see a meshwork of nerve, a plexus, which is formed by the tympanic nerve. The tympanic nerve is coming through the tympanic canaliculus. It's the branch of the glossopharyngeal nerve. It will form a plexus on the surface of the promontory, and after it will continue as a lesser petrosal nerve, nervus petrosus minor, on the top of the petrosal part of the temporal bone. What are the other structures what we can see here? These are the auditory ossicles. I will show you that later. And also it is really important to mention that here you can see the facial nerve. The facial canal has a very strong connection with the tympanic cavity, because it will run on the superior and the posterior, behind the superior and the posterior wall of the tympanic cavity. So if you see, so this was the anterior wall of the tympanic cavity with the membranous, and the anterior view with the membranous wall, and the labyrinthic wall, which is the medial wall. But here we changed the view, and now here we see the tympanic cavity through the eardrum. So in this case, this will be the superior wall, the anterior wall, the posterior, the inferior wall, and the posterior wall of the tympanic cavity. Everywhere you can see one very special structure, and that's why it will be the origin of the name of the different walls. So if you see the superior wall, on the superior wall of the tympanic cavity, we can see a very thin bony part. This part is called the tegmen tympani, you know, the part of the pars petals or part of the temporal bone. And that's why it's called the tegmental wall. The superior wall is called the tegmental wall. After there, here anteriorly, there, the main structure there is the internal carotid. So that's why we say, for the anterior wall, the carotid wall is here. Inferiorly, we can see the internal jugular vein. So that's why the inferior wall is called the jugular wall, internal jugular vein. And finally, posteriorly, we can see the mastoid process. So that's why the posterior wall is called the mastoid wall of the tympanic cavity. And now, because unfortunately we have no direct practices, so that's why I would like to draw together the tympanic cavity, the most important structures there, how we do in our practices, in my practice with my students. So I would like to ask you that please take one sheet of paper, a white paper, and I would like to draw with you the tympanic cavity. So let's draw this very special rectangular shaped structure. This will be here, the labyrinthic wall. Here we will draw all of the structures of the labyrinthic wall. There, superiorly, this will be, here will be the structure of the tegmental wall. And this is the anterior, the carotid wall. The inferior is the jugular wall. And finally, posteriorly, here we can see the mastoid wall. So these are the five main parts what I would like to describe with you and I would like to draw with you. So let's see here the first wall, which is called the labyrinthic wall. In the labyrinthic wall, I told you the main structure is the protrusion of the cochlea. This protrusion is called promontory. You can draw a very big bubble there in the middle, which is called the promontory. On the surface of the promontory, you can see the tympanic nerve is coming through the tympanic canaliculus from the glossopharyngeal nerve. After will from here the tympanic plexus, and finally it will continue as the lesser petrosal nerve, which will go through the superior wall. And there, here in the middle wall, you can see two foramens, the windows. The upper is called the oval or vestibular window. Here will be fixed the base of the stapes. And the lower window is called the round window or cochlear window, which is covered by a secondary tympanic membrane. It will have really important function to withdraw the unuseful part of the waves, of the sound waves at the end of the cavity of the internal ear. We will talk about this membrane later. And here we have to mention the protrusion, which is formed by the facial canal. It is the prominence of the facial canal on the superior and the posterior wall. And there upward we can see, it's a little paler in this diagram, but you can see that the upper part is formed by the prominence of the semicircular canals, which are located there in the upper superior part of the tympanic cavity. So these are the structures what we have to mention if we describe the middle wall of the tympanic cavity. Let's continue and let's see the anterior, let's see first here on this picture the tegmental wall, which will form the superior border of the tympanic cavity. So here you can see the tegmental wall and the two main structures which are running there through the tegmental wall. And these are the two nerves. The one is the branch of the facial nerve. This is here the greater petrosal nerve, We know that the greater petrosal nerve will bring the preganglionic parasympathetic fibers towards the pterygopalatine ganglion, and after the postganglionic fibers will attach to the branches of the maxillary nerve and will supply the lacrimal gland and the smaller salivary glands of the nasal and the oral cavity. After this small, it will be the continuation of the tympanic plexus there. It's called the lesser petrosal nerve. This is from the glossopharyngeal. It will bring the preganglionic parasympathetic fibers to the otic ganglion, and after the postganglionic fibers will attach to the auriculotemporal nerve and will innervate the very big, the carotid gland. So these are the nerves what we can find on the top of the tympanic cavity. Let's continue the description of the anterior wall. It's called carotid wall. Here the main structure will be the internal carotid artery. You can see the internal carotid artery has a bony canal, and that's why here this very direct connection is that you can hear, if you're lying on your ear, you can hear the pulse, your pulse here, because it is so close to the tympanic cavity, and through this bony wall we can find structures, small canaliculi. These are the caroticotympanic canaliculi. There we can find very small nerves which will originate from the sympathetic plexus, which will run with the carotid artery, and of course the smaller branches, smaller arteries too, which will supply the tympanic cavity. On the upper part of the tympanic, of the carotid wall, there will be the opening of the auditory tube. We know that the auditory tube will form the connection between the tympanic cavity and the pharynx. So this is the auditory tube there. And on the top of this canal, this was the musculotubal canal, there will be a muscle, which is the musculus tensor tympani muscle, which will fix to the manubrium of the malleus. I will show you later. We'll push backward the manubrium to, if you would like to stretch the eardrum, if you would like to hear better the voice, which is not so loud. So it is together is called the musculotubal canal, which will contain these structures. And after, I would like to show you the inferior wall. It's called the jugular wall. Here in the jugular wall we can see the internal jugular vein. Here I would like to take your attention to this very strong connection between the jugular vein and the tympanic cavity. So the inflammation maybe can cause problems with the venous circulation. And there is the tympanic nerve, which is the branch of the glossopharyngeal. We can see the proximal part of the styloid process, and behind the styloid process you can find the stylomastoid foramen, where the facial nerve will go out here through the skull. And finally, here you can see the posterior wall of the tympanic cavity, which is called the mastoid wall. It will have connection with the air-filled cells of the mastoid process, which is called mastoid antrum. And there in the posterior wall we can see also a triangular shaped protrusion, which is called the pyramidal eminence. Within this eminence we can find the stapedius muscle, the smallest muscle of the body, smallest skeletal muscle of the body, which is innervated by the stapedius nerve from the facial nerve. And there you can see also the origin of the last branch of the facial nerve, which is called the chorda tympani. Chorda tympani is running through the tympanic cavity, and it will have fibers, preganglionic vegetative fibers, and also special viscerosensory fibers from the anterior two-thirds of the tongue. And now, just only this, I would like to mention that here we could have information too in the mastoid process, and it's called mastoiditis, and because it will communicate with the tympanic cavity, that's why we have to treat it as soon as we can. And finally, if you finish, you have this schematic picture together with all of the important structures what you have to know in the tympanic cavity. The next preparation, so here in the anatomy practices, for the demonstration of the tympanic cavity, we can use a real preparation here and the plastic preparations too. So unfortunately now you are not able to see it. Of course we will do an extra demonstration part when I'm showing you the structures for you. But here you can see the pictures of this preparation. So this is the two parts of it. This is the eardrum with the lateral wall of the tympanic cavity. This is the anterior wall here, posterior wall. Here you can see the middle wall. So let's see what are the structures what we have to show there. If you see the membranous wall of the tympanic cavity, of course we can see the eardrum there. The malleus is visible too. And this is the opening of the auditory tube in this case. And in the upper part, you can see the muscle, the tensor tympani muscle, and you can see that the tendon of it is fixed towards the malleus. Also, it's visible the nerve, the cord tympani, which is the branch of the facial nerve there. If we see the other view, this will be the middle wall of the tympanic cavity with the promontory. On the surface of the promontory we can see the tympanic nerve, and also the facial canal is visible in these preparations. This is the facial nerve there, and the proximal part of the greater petrosal nerve is also visible there. And if we see with higher magnification, there you can see the stapes, which is fixed towards the window here to transport the waves from the external and medial ear to the internal ear. And there in the anterior wall, you can see the carotid artery, there the carotid canal. And posteriorly, the stapes, what I told you before, and the semicircular canal. This is the posterior view. So here if you see the posterior cranial fossa, the internal acoustic meatus is visible on the picture, and there posteriorly we can see the sigmoid sinus, and of course these are the semicircular canals in this preparation. This is the plastic one, the plastic preparation with the tympanic membrane. There you can see the auditory tube and the tensor tympani muscle and the cord tympani. Here, auditory ossicles. And this one here is the other wall, the medial wall. There we can see the promontory with the stapes, the facial canal, and the mastoid process, which is located there posteriorly, and the pyramidal eminence with the stapedius muscle. We know it is innervated by the stapedius nerve from the facial nerve. And anteriorly there we can see the internal carotid. So I will show you in the demonstration part, I will demonstrate for you these preparations. And finally here, it is really important to talk about the facial canal. And here you can see the figure illustration about the branches of the facial nerve. There you can see the main nuclei of the facial nerve here is listed. One is missing, which is the tractus spinalis nervi trigemini, but you can see the main motor nucleus, we can see the vegetative nucleus, and visceral motor nucleus, and we can see the viscerosensory nucleus of the facial nerve. So if you see the facial canal, the opening of the facial canal will be the internal acoustic meatus. There the facial nerve is running first perpendicularly to the axis of the petrosal part of the temporal bone. And here the first branch will be the greater petrosal nerve, is here. It will bring the preganglionic fibers to the pterygopalatine ganglion, and after the postganglionic fibers will innervate the lacrimal gland and the small glands in the nasal cavity and the oral cavity. After the canal will run parallelly with the axis of the petrosal part of the temporal bone, and there in the angle we can see the sensory ganglion with pseudo-unipolar cells. Is called the geniculate ganglion, ganglion geniculi, where we have the pseudo-unipolar cells which will connect the information from the tongue. Also the special viscerosensory and somatosensory, general somatosensory fibers will, pseudo-unipolar cells will be here. After the next branch will be the stapedius nerve, is a motor nerve of the muscle. And finally the chorda tympani, which will bring the preganglionic vegetative fibers and also the special taste fibers. Here you can see it's running through the chorda tympani. I think you mentioned with your group leader the special symptoms of the facial palsy. Here you can see if we have a central lesion. In this case, because it has the facial nuclei, they have bilateral innervation. In a case of central lesion, the patient is able to move the upper muscles there above the eye, but the others not. But in the case of peripheral lesion, of course, all of the peripheral muscles, they are not able to, they won't be movable, yeah, and because so for example, the patient is not able to close the eye or to smile in this case. But if you see these branches, of course, we have other symptoms too. For example, the patient has a dry eye, dry nose, and dry mouth because of these special visceral motor fibers, the lesion of the visceral motor fibers. Of course, it has problem with the tasting. And the other very special symptom is the hyperacusis because of the lesion of the stapedius muscle. The stapedius muscle is pushing backward the stapes from the foramen to protect the inner ear from the very loud sound. And in this case, the different voice, they will be painful for the patient in case of hyperacusis. I would like to continue with the description of the tympanic cavity. We can divide the tympanic cavity into three main parts based on the level of the eardrum. The upper part is called the epitympanum, the middle part is called the mesotympanum, and finally the lower part is called hypotympanum, which will have connection with the pharynx, with the auditory tube. And this whole part, it has connection with the antrum, which is located in the mastoid process. So here you can see the cavity and the division of the tympanic cavity. So let's see here the details of the eustachian tube, the auditory tube. The auditory tube is located between the tympanic cavity and the pharynx. Here you can see the pharyngeal opening of the eustachian tube. What's the function of this structure? To equalize the pressure between the tympanic cavity and the environment. For example, if you are sitting in a plane, for example, then you have to equalize the pressure because you know lower pressure will be outside. We have a bony part and we have a cartilaginous part, which is formed by elastic cartilage. And in the middle part is called isthmus. And here you can see the tympanic orifice, and here the pharyngeal opening of the auditory tube. And there you can see the cartilages which will form the wall of the tube, and from this cartilaginous wall will originate the tensor veli palatini muscle. So that's why if we swallow, we stretch the tensor veli palatini, and this is the way how we can open the Eustachian tube. What's happening if this tube is closed? For example, childhood is really frequent because of the enlarged pharyngeal tonsil. It could be closed. In this case, they are not able to form connection between the pharynx and the middle ear, and the pressure will be lower, and the special exudate, which is called ear glue, will be developed, which will surround the ossicles, and the ossicles, they are not able to move, so that's why the children, they have problem with the hearing. So of course, in this case, we have to do an artificial connection between, of course, we have to operate first the pharyngeal tonsil, and if it does not work, in this case, we have to do an artificial connection between the external ear and the tympanic cavity. We can do a very small structure, which is called a chromatis, a very small tube. I will show you in the demonstration part later. And this is the way how we can form connection between the tympanic cavity and the external ear. Here you can see the YouTube video, which is forming for you the development of the glue ear. And finally, in the last part of my lecture, I would like to show you the auditory ossicles, which are the structures of the tympanic cavity. In the aurically, the ossicles are the malleus. This is the first, the malleus, after the incus, and finally the stapes here, which is located there. They will form a bone chain, and they are attached to each other with different joints. What are the parts of the bones? So first, if we see the malleus, it has a manubrium, a proximal part, which is fixed to the eardrum. And after, here I can show you two processes, a lateral process, which is facing towards the eardrum, and the anterior process, which will continue to a ligament. And there I can show you the neck, and finally the head of the malleus, and it will form a joint with the next bone, which is the incus, and this is the articular surface of the incus. It's so similar to the molar tooth. So this is the incudomallear joint, which has a saddle shape. Of course, we have no movement between these two bones. It's a fixed joint. And here you can see the two processes of the incus, the short, which is located posteriorly, and the long, which is going downward. It will have really important function that the long process of the incus will be parallel with the manubrium of the malleus. And finally, there we have a perpendicular process. Is the lenticular process. In the perpendicular angle, it will continue to the stapes. This is a joint between the two bones. And finally, the basis of the stapes is fixed to this window, and this is how we'll transfer the waves, from the external ear through the tympanic cavity to the internal ear. This is the oval window I told you, and there we have a ligament which will fix the base towards this foramen. And finally, I would like to show you the ligaments. Of course, it's not necessary for you to know all of the names of the ligaments, but you can see that these bones, they are fixed towards the superior wall of the tympanic cavity, also anteriorly and also posteriorly to the wall of the tympanic cavity. And here I would like to mention for you this part of the tympanic cavity, which is located between the head of the malleus in the epitympanum. This is the Prussian pouch or the superior recess. Here we could have so frequently inflammation in the tympanic cavity. And finally, if you check this movie here, you can see the movement of the bones. We will demonstrate for you the movement of the bones in the demonstration part. So here you can see how the waves will move the eardrum, the monoprium will move, and because here we have a fixed axis, the long process of the incus will move in the same direction, and finally it will move the stapes in and out within the window, and this is the way how it will transfer the movement from the eardrum to the internal ear. And finally, I would like to show you the muscles. I mentioned the tensor tympani muscle, which is innervated by the trigeminal nerve. This is, here you can see, is fixed to the monoprium, so it pushes backward, stretches the eardrum if you would like to hear something better. And the other is the stapedius muscle, which will be fixed to the stapes, to push backward the stapes, to protect the ear from the very loud sound. And this is innervated by the fascia. Here you can see all of the nerves which are involved within the innervation of the tympanic cavity. I told you the glossopharyngeal, but the vagus has also branches. We have parasympathetic fibers from the auriculotemporal nerve, and with the carotid plexus will run the sympathetic fibers. And you can see the arteries, the maxillary artery, the internal carotid, the ascending pharyngeal, and the middle meningeal artery. They have also branches which will supply the tympanic cavity. And finally, I would like to thank you for your attention.